Hello, good afternoon. So our next session will be with Professor Ketan Dhatariya. He's a consultant in diabetes and endocrinology. He's a professor of medicine at Norfolk and Norwich University Hospital, UK. So he will update us about the emergency, hyperglycemic emergency guidelines in adults. So he will talk about the new consensus on the management of DKA and HHS.
Hello everybody, my name is Ketan Dhatariya and I'm a diabetes doctor from Norwich in the United Kingdom. And I'd like to thank the organisers for inviting me to give this talk on the most up-to-date consensus document on the management of hyperglycemic emergencies. What I'm going to do in the next few minutes is just take you through the history of what's been going on in the world of DKA and hyperglycemic emergencies, in particular HHS as well, and then go through the new global consensus document with you. So bear with me, let me go through it, and hopefully this is going to take about half an hour or so. So these are my conflicts of interest, none of which are relevant to the talk today. Let me first of all start by telling you who I am. I qualified a long time ago, sometime in the last millennium. I trained in diabetes endocrinology in and around London in general medicine. I did general practice for a couple of years. Importantly, I did intensive care and anesthetics for a year as well. I did my research in the United States in the Mayo Clinic, and then came back and was in Norwich, and that's circled in the small red circle you can see there. It's a small town in the east of England where I've been since 2004. But more importantly for this talk, one of the things that I've been doing is that I'm currently the chair of the Association of British Clinical Diabetologists, which is an organisation that represents diabetes doctors in the United Kingdom. I'm the immediate past chair of the Joint British Diabetes Societies for Inpatient Care, which is of course how I got involved in DKA, and I'll go through that in just a moment. I also chair the exam board for the higher specialist exam in endocrinology, which many people in the Middle East and India are doing at the moment, as you know. So let me give you a timeline for the history of hyperglycemic emergencies, in particular DKA. So as you all know, DKA prior to the discovery of insulin was universally fatal. It was in about 1857, and there was a thing called the Siege of Paris, where somebody realized that if you starved individuals and gave them a very, very low carbohydrate diet, they actually would live a little bit longer, but ultimately, of course, it was universally fatal. The discovery of acetone in the urine as the predominant problem that was found in those people who were dying from DKA was identified. And of course, in about 1850 or 1870 or so, a chap called Julius Dreschfeld at a lecture in the Royal College of Physicians in London described two different kinds of diabetic coma. The first one was in those people who rapidly lost weight and were very thin and had characteristic breathing, which we now recognize, of course, as DKA and Kussmaul breathing. And the second one was in those people who are really very overweight, who just fell into a coma eventually and died without that kind of breathing. And of course, we know that now as hyperosmolar hyperglycemic state. Kussmaul then described his breathing that we all understand, and of course, then the whole world changed in 1921 and 1922 with the discovery of insulin and the administration of it for a first time. And of course, as we all know, we wouldn't all be here if it wasn't for that discovery. But with the discovery of insulin, there came a difficulty in knowing how to treat people. So this is Elliot Joslin, and he was in the United States at the Joslin Clinic in Boston, and he first published his DKA protocol, where he gave very, very gentle fluid replacement, and he described the survival of 31 out of the 33 patients that he first treated. But on the other side of the Atlantic, in the United Kingdom, we had R.D. Lawrence, who himself, of course, had type 1 diabetes. He was advocating for extremely aggressive fluid replacement because these people were dying of dehydration. So there's always been this dilemma between how fast you give fluid replacement therapy. There's also this dilemma of how much insulin you give. And in the first few years, certainly in the 40s and 50s and 60s, there were many, many reports of people giving thousands of units of insulin per day, because that was what was thought to be needed to switch off the ketosis, improve the hyperglycemia, and the doses of insulin were dependent on what was thought to be the perceived prognosis of that individual. The more likely they were to die in the next 6 or 12 hours, then the higher the doses of insulin that were administered. But that then led to 3 consecutive papers published in the same edition of the British Medical Journal, which showed that low-dose intravenous insulin infusions reduced ketones and glucose at the same rate as those people who were given high doses. And that's why they advocated for low-dose intravenous insulin. And that was then replicated in the New England Journal of Medicine by Abbas Kitabchi and colleagues, who are, of course, very famous for their work in DKA. At around about the same time, there started becoming reports being published about the risks of a condition called cerebral edema. It's particularly in children. And then there was this whole issue about whether you give normal saline or do you give it half normal saline, do you give it rapidly or slowly? And the trend was thought to be that you needed to give it slowly to prevent the rapid changes in electrolytes to reduce the risk of children in particular developing cerebral edema. In 2001, the American Diabetes Association published their first guideline on management, particularly of DKA and HHS, and I'll come back to that in a moment. In the UK, we published our guideline in about 2011, and then, of course, in 2015, 2016, with the publication of EMPA-REG and the use of SGLT2 inhibitors, then the increasing problem with euglycemic DKA became more apparent. I'll come back to this. I wrote an editorial in 2017 in the Lancet Endocrinology saying that actually the American guidelines were no longer fit for purpose, and I'll show you why that was in a few minutes. Then there was this study published by Nicole Glaser and colleagues, which was the largest randomized control trial of fluids and rate of fluids published in children, showing that actually the risk of cerebral edema was entirely an idiosyncratic effect. It didn't matter on which fluid was being used or how fast it was being used. That wasn't what was responsible for the development of cerebral edema. There was data published from the United States, particularly from the CDC, the Centers for Disease Control, showing that actually mortality from DKA was really plummeting to less than 1% in many developed nations, but in other nations of the world where access to care was not as easy, mortality still remained as high as 30%. We published the up-to-date guideline in the United Kingdom, most version in 2022 and 2023. And of course, as you all are aware, hopefully we've updated the global consensus document published in the summer of last year. I'm going to take you a bit of background as to how I got involved. This is very briefly. This shows a rugby game that I was invited to. I'm not a rugby fan, but this is the only game I've ever been to, but it does show you how old this is because you can see the sponsors were Lehman Brothers. And during the journey to this game, I was accosted by an anaesthetist colleague of mine who kept on saying to me, why do diabetes doctors insist on using normal saline as the fluid resuscitation of choice in people who present with DKA? And I was a new consultant at this time, and I said, well, that's because that's the way it's always been done. And I didn't really question it until then, until this colleague just kept on going at me. And so as a result of this, I decided to go away and do some reading. And what I did is I then published an editorial in the British Medical Journal to show that actually normal saline was usually very safe, and it's been used for a very long time, and it's the drug which is most frequently available in most institutions without any problem. Now, I have to tell you that when I wrote this, I got hundreds and hundreds of emails, usually hate mail from all over the world, usually from anaesthetists who told me I didn't know what I was talking about. But as a result of this, I was invited to join the writing group for the then very new joint British Diabetes Societies for Inpatient Care, who are writing a national guideline, national protocol for the management of diabetic ketoacidosis. So I joined that group, and eventually I actually became the lead author on that document. But one of the questions we always have to ask ourselves is, even though we've published a guideline, which was by and large consensus-based, there was some, of course, evidence to what we were suggesting, but how did we know that what we were suggesting was actually correct? And that was the right thing to do, and that people weren't coming to harm? And so what I did back in 2014 is we carried out a national survey. We knew from our previous work that the guideline that we'd written by the Joint British Diabetes Societies was taken up by 95% of all UK hospitals within 2 or 3 years. And so it was very widely used. And so we then could judge whether what we were doing was correct or not. So we did this national survey, and this is the paper that was published as a result. And what we found was that actually there were a large number of people who were still developing hypokalemia and hypoglycemia. And as a result of this, we changed the document, because what we had originally said is that you use 0.1 units per kilo per hour of insulin, regardless of the glucose. But as a result of this, we changed our guideline, and we said, actually, when the glucose drops down to less than 14 millimoles per mole, so that's 250 milligrams per deciliter, we drop the insulin infusion rate to 0.05 units per kilo per hour, but add in dextrose in addition to the saline as the substrate for the insulin. So we have changed things. Let's go back to what the Americans did. So this is the first guideline published by Abbas Kitabchi and colleagues in 2001, and they updated it in 2006. And the very last iteration was only published in 2009, so a very, very long time ago. Now, there were differences between the US and the UK documents, and these are just some of the I'll show you. So this is what the ADA used to say. So, and many of you may have used this. And what it says here, I want to just take you through their guidelines. So it says mild, moderate, and severe, and you had to have a glucose above 250 milligrams per deciliter, so above 13.9 millimoles per liter. And then, depending on the severity, depending on the anion gap or the mental state, and so on, would determine the criteria of severity. But there were some issues, and in the UK, we wanted to make things as simple as possible, and so this was the diagnostic criteria that we used. So you either had to have a glucose above 11.1, or you had to have a history of diabetes, you had to have a ketone concentration above 3 millimoles per litre, or greater, 2+ or greater of urine dipsticks, and you had to bicarbonate of less than 15 millimoles per litre, or a venous pH of less than 7.3. So we wanted to make it as easy as possible. Now, why did I think the Americans were wrong? Well, because first of all, there was no insistence on having the D, the K, and the A to diagnose DKA. Now, I think that's something that should be straightforward, but it was not the case previously. There was no clear acknowledgement of euglycemic DKA. So one of the things that we said, of course, is that in every single other walk of life, if you had a glucose above 11.1, so 200 milligrams per deciliter, you'd have diabetes, unless you were newly presenting with DKA, where, according to the Americans, you could only have diabetes if your glucose was above 250 milligrams per deciliter, which I thought was a nonsense, really, and was an area which could have been improved on. And of course, you could get euglycemic DKA, and in the 2009 document, there is one line out of this, I think, 10 or 15-page document that says, yeah, glucose could be normal. So there's no insistence. So that with the advent of SGLT2 inhibitors, that became more important, of course. In the United States, even to this day, bedside ketone meters are not really available, and so ketones are often a send-away test to a central laboratory. It can take hours to come back. And of course, the K is how you can manage bedside monitoring. You can manage DKA. You can adjust insulin concentrations and fluids and so on an hourly basis if you need to. And there was no insistence on the continuation of subcutaneous insulin. So that's why I wrote this document with Guillermo Emperez, actually, to say the ADA needed to update their document. And we wrote this in 2017, and it took them quite a long time to actually agree. So this is what happened actually before 2022, they said, yes, we do it. And so we wanted to make it a multi-agency global consensus document. So these are the authors representing the American Diabetes Association, the European Association for the Study of Diabetes, the American Association of Clinical Endocrinology, the Joint British Diabetes Society for Inpatient Care, and the Diabetes Technology Society. So a truly global organization and consensus document. And you may have seen these were published simultaneously in Diabetes Care and Diabetology last year. So what was the objective of the consensus document? Well, it was, as you can see here, it was to go through all of the literature, which is what we did, to provide the most up-to-date evidence-based document that we could, and where there wasn't any evidence, to ensure we had a robust consensus. And I'll explain to you where and when that changed, and what areas that there isn't still consensus, but we've highlighted that in the document. And it's for everybody who is treating DKA, people at the front door, people in the wards, people in ITU and so on, wherever people with DKA and HHS are looked after. Now, normally in the UK, if you've seen that document, and all of the documents published by the JBDS, what we've always done is to try and do the how, which is to say, well, what do you actually do? The practical guideline of the minute-to-minute or hour-to-hour management of all of the emergencies that we deal with and all of the things that are in the front door. And then there's a section at the back as to why we're doing what we're doing and why do we actually say what we say. Now, the ADA don't work that way necessarily, and so what they've done is they've come up with a series of questions, as you can see here, and these are what we've had to answer, but at the same time go through the pathophysiology and then the treatment as well. But I'm not going to answer all of these questions in this presentation today for lack of time, but they're all available in that document which I've already mentioned. So let's go through the pathophysiology. This hasn't changed, of course, and it's much the same as it's always been. So people present with usually infection, which is by far and away the most common cause of the precipitation of hypoglycemic emergencies. Insufficient insulin administration, of course, stress or medication errors, and of course people who are newly diagnosed. Now, if we talk about DKA in the first instance, you have absolute insulin deficiency. That leads to a lack of suppression of gluconeogenesis in the liver, which then leads to high glucose concentrations, and glycogenolysis, which also occurs, leads to a rise in blood glucose concentration. But at the same time, if there's no insulin on board, you cannot take insulin up into the skeletal muscle or into the adipose tissue. And then what happens is that the adipose tissue starts breaking down to liberate free fatty acids from lipolysis and liberation of glycerol, which again increases the hepatic secretion of glucose. With the free fatty acids, that will go to the liver to produce ketone bodies, and that of course will lead to hyperketonemia. Hyperketonemia is not necessarily a bad thing, but it's the rate of appearance of ketones and the inability to compensate either renally or respiratorily, which leads, of course, to the acidosis that one gets with the excess accumulation of ketone bodies. That's why you get the ketoacidosis. At the same time, you get an increase in counter-regulatory hormone secretion, which then further inhibits glucose utilization, increases gluconeogenesis and glycogenolysis. And of course, if you start getting breakdown of amino acids from the skeletal muscle, that increases, particularly if you liberate the gluconeogenic precursors, that increases the amount of glucose in the circulation. That all together leads to hypoglycemia, which leads to the glycosuria and osmotic diuresis and electrolyte loss, leading to volume depletion and again, impairment of renal function. And that leads to the hyperosmolality. And that can be, of course, if you've got HHS as well. But if you then if you add in oxidative stress and inflammation, which then leads to endothelial damage, that's further problems. If you think more about the HHS here, you've got a relative insulin deficiency, but that then leads to decreased glucose utilization. But you've got sufficient insulin sensitivity and sufficient insulin concentrations to not necessarily have an effect on the lipids, adipose tissue, therefore you don't necessarily get the ketone production, but we'll come back to that in just a second. But at the same time, if you get decreased glucose utilization, you still get the hypoglycemia, you get that vicious circle of osmotic diuresis, volume depletion, renal impairment, and the hyperosmolality. And therefore, that's the spectrum of DKA and HHS that you can see. As I mentioned, we had to harmonize the diagnosis of DKA, and you can see it here. So it's a glucose above 200 milligrams per deciliter, 11.1 millimoles per liter, or a prior history of diabetes. It's a beta-hydroxybutyrate of 3 millimoles per liter or greater, or urine ketone strips of 2+ or greater, and a metabolic acidosis with a bicarbonate of less than 18 millimoles per liter, or a pH of less than 7.3. So what are the changes? Well, if you use the American guidelines, these are the changes to the D of diabetic ketoacidosis. So we've lowered the threshold for diagnosis of diabetes to what everybody else uses. It's come down from 250 milligrams per deciliter to 200, 11.1 millimoles per liter. We've added in, you could have had a complete normal glucose, so you've had a prior diagnosis of diabetes. So if you're on an SGLT2, your glucose could be absolutely normal, but you could be quite profoundly acidotic, for example. So that's why a prior history of diabetes. And therefore, both of these changes are to allow for that diagnosis of euglycemic DKA. A change to the K of the DKA, well, we've got quantitative cutoff, so beta-hydroxybutyrate of 3, or of course a urine ketone, which of course is not beta-hydroxybutyrate, it's usually acetoacetate, which is not the predominant ketone in the blood, it's only the ketone in the urine predominantly. And the reason is because, as I mentioned, beta-hydroxybutyrate is converted into acetoacetate in the urine. And therefore, if you're only measuring urine ketones, there's a problem. The first one is that it's an average of the urinary ketone concentration since the bladder was last emptied. So, because it could be hours, of course, particularly if you're dry. And because beta-hydroxybutyrate is converted into acetic acid, then actually there's a delay. So you get urine ketones which appear for far longer in the urine than there is beta-hydroxybutyrate in urine because it's been converted. And of course, there are interfering substances that could alter your interpretation of urine ketone sticks. Changes to the A for DKA, well, the acidosis, it's a pH of less than 7.3 and a bicarbonate of less than 18. So if you use the UK guideline, we've moved from 15 to 18 millimoles per litre. We don't use the anion gap anymore. It was part of the US guideline, but we don't use it predominantly because you can get bedside ketone measurements using a standard meter in this day and age. And it's something about the document that we wanted to make it aspirational. So if you don't have it, we recommend that you get them because they are so commonly available in most parts of the world that we try and say that's the way you should be now using this new tool. Let's move on to treatment. So of course the predominant treatment is divided into fluids, insulin and potassium. And I'll go through each one in a moment. So with the fluids, you have to use your clinical judgment to determine the hydration status. If somebody's severely hypovolemic, mildly hypovolemic, or if they've got cardiac compromise, then there are different things that you can do. If somebody's severely hypovolemic, of course, you want to give them normal saline, 0.9% sodium chloride solution, ideally a litre an hour or more should they need it. However, if they've got mild hypovolemia, then you can give the same, but there are now data, there are at least 3 randomized controlled trials to show that other balanced crystalloid solutions are equally as good. And because you do not get the hyperchloremic metabolic acidosis that you get with large volumes of normal saline, there is a shorter length of hospital stay. And so there is an argument to use balanced crystalloids in people with DKA, but they are of course more expensive than 0.9% normal saline sodium chloride solution. So if you've got mild hypovolemia, you want to try and correct at least 50% of the fluid deficit in the first 8 to 12 hours if you can. If somebody's got cardiac compromise, then they almost certainly need to go to an intensive care unit where their hemodynamic status can be monitored very closely, however that may be needed, and the administration of vasopressors may also be necessary. And when the glucose reaches less than 250 milligrams per deciliter or 13.9 millimoles per litre, you add in dextrose, and that could be 5 or 10% dextrose, to the saline or balanced crystalloid solution, because the balanced crystalloid or saline will act as the resuscitation fluid and the dextrose will act as the substrate for the insulin that you're requiring to prevent them from becoming hypoglycemic and we'll come on to the hypokalemia in just a moment. Now, with the insulin, you've got mild DKA, moderate or severe DKA, and HHS, and there are slight differences here. So with mild DKA, because we've written the document that could be used anywhere in the planet, in any health resource environment, we've said you could potentially use subcutaneous insulin. And there are some very good studies to show that subcutaneous insulin is equally as efficient in managing DKA as somebody who's got moderate or severe DKA. And the dose that you would use is exactly the same. It's 0.1 units per kilo per hour, or you give, if there's a delay in setting this up, you could potentially give them 0.2 units per kilo every 2 hours. Here we go. So that's what you could do. But if you've got moderate or severe DKA, then you'd give them intravenous insulin because there's almost nothing more. Because if you're peripherally shut down, then subcutaneous insulin may not be able to work there. And again, you'd give 0.1 units per kilo as a bolus dose if there was a delay in setting up the infusion. Otherwise, you'd give 0.1 units per kilo per hour as an intravenous insulin infusion, as a fixed rate intravenous insulin infusion. Now, if you've got HHS, you would give them IV insulin. Now, there are some differences of opinion here, because what we've said in the UK and in this document, in the global consensus document, is actually that if you just give fluids in HHS, you would only give insulin once the glucose concentrations have stopped dropping. And the reason is because if you give intravenous insulin at the same time as the fluids, then the rate of change of osmolality may be great enough to cause osmotic changes in cerebral osmotic demyelination. And so to avoid that risk, we have said, or some of us have said, that you need to give the fluids first, and only when the glucose stops dropping do you add in the fluids. Others have said that's not a problem, we can give both together. And this is one area where there was no consensus because the data are so poor in the literature. So it's up to you how you do it, whether to only give insulin once the glucose has stopped dropping or whether to give insulin at the same time as the fluids. But when you do decide to give insulin, you need much less than in DKA, and you just start with 0.05 units per kilo per hour as a fixed rate intravenous insulin infusion. And then when the glucose reaches 250 milligrams per deciliter for DKA or 14 millimoles per liter, you then reduce the dose in DKA to 0.05 units per kilo per hour. Now, also at this stage, there is whether you wish to continue long-acting subcutaneous insulin, because some people do feel that that is what should be done, and that's what we've done in the UK for many, many years, in addition to the intravenous insulin, because there's data to show that it actually prevents the rebound hypoglycemia when you come off the insulin, or the intravenous insulin. But others say, no, that increases the risk of hypoglycemia. So that's the differential. Now, for potassium, there are three issues. First of all, you need to make sure that you've got adequate renal output. And the way to do that is you've got to have a minimum urine output of 0.5 mils per kilo per hour, which establishes that you've got sufficient renal function to give you somebody potassium. If your potassium is less than 3.5 millimoles per litre, then what you do is you can give them 10 to 20 millimoles per litre of potassium, or faster if you have access to cardiac monitoring, of course, but it would need to go through a large vein, possibly even centrally. If your potassium is greater than 5, then you don't add in insulin. As you don't add in potassium to the first bags, you give them the insulin. That, of course, will drop the potassium, and then you only add in potassium once the levels have dropped to less than 3.5 millimoles per litre. And if it is, then you give them 10 to 20 millimoles per litre per hour, or per litre of fluids, to keep it between 4 and 5 if you can. You need to check their electrolytes every 2 to 4 hours. You can use venous blood gas for many people if you have access to that. And then when people are eating and drinking and they're resolved, their DKA or HHS, there's methods in the document on how to transfer to subcutaneous insulin. We say do not give bicarbonate routinely, and even if the pH is less than 7, really only consider it at a last resort. Most people do not need bicarbonate. Similarly with phosphate, it's not normally necessary unless people have got some kind of respiratory compromise, because it's so low. There is an issue about DKA severity, ketone concentrations between 3 and 6, mild to moderate, greater than 6 for severe, and then the acidosis and suggested level of care. Now, these are all mix and match, but we say very clearly that it is actually clinical judgment that should determine where that individual is looked after, not according to a table. And here we go. These are the criteria for resolution for DKA. So you've got to have a ketone concentration of less than 0.6, a pH of greater than 7.3, or a bicarbonate of greater than 18, and a glucose also back to normal of less than 11 millimoles per litre, 200 milligrams per deciliter. That's what we've decided as criteria. Let's move on to HHS in the last few minutes. So we've got to have a glucose above 33.3, so 600 milligrams per deciliter. You can either calculate the total or effective osmolality, depending on whether you've got the urea or not, so 300 or 320 milliosmoles per litre, absence of ketonemia or ketonuria, and an absence of an acidosis. But we also have said there are data now to show that about a third of people presenting with a hypoglycemic emergency have a mixed DKA and HHS. And if they have that, they should be treated as DKA, because it's the acidosis that does the harm and kills people. The treatment I've already gone through, and these are the criteria for resolution. So a calculated serum osmolality of less than 300, hypovolemia has been corrected, cognitive status has improved, and their glucose is down to less than 250 milligrams per deciliter. There are, of course, lots of gaps in our knowledge on the management of DKA, and this is just something that we've discussed in this manuscript. Just in the last few minutes, there's an ongoing global consensus data collection exercise which you could be involved in, called DCODE, the Digital Evaluation of Ketosis and Other Diabetes Emergencies, run by a colleague of mine from Birmingham. And these are some manuscripts that he's published. If you want to be involved, it literally involves an app You get your junior doctors or medical students to fill out an app. It takes about 2 or 3 minutes per person admitted with DKA, and we're collecting data on thousands and thousands of individuals to allow us to look at the effect of different drugs, different technologies, and so on. If you want to be involved, just ask. My contact details will be on the end, on the very last slide. And so it's now international, and if you're interested, then feel free to contact me. If you are interested, this is a very comprehensive review on the management of DKA, which of course you can download. And with that, ladies and gentlemen, I'll say thank you very much for your attention. Have a good afternoon, and I hope you enjoy the rest of the conference.